surrender. Just let your love flow like a mountain stream and let your love grow. Smallest of dreams and let your love show. And you'll know what I mean. It's the season. Let your love fly.
Contactless technology from Barclaycard, making payments simpler.
Okay, so welcome to the Innovation and Improvement Forum, and it's fantastic to see so many people here. A bit scary really for me, but that's fantastic to see so many people. Whakatane was also going to dial in, and so if I have to go to my technology, I will, but I might need to call help as well. So currently we're having this every 2 weeks. We had to shift it into this room to fit everyone in. Boy, there's a lot of people here, that's great. So we're just reviewing the frequency and the time. The first thing that I want to do is a bit of a major personal challenge, but it's in line with change, and if you're wanting to be a change agent, then you kind of need to take some risks. So here's a major personal risk for me. But in order to do that, what I want you to do is to stand up and help me with this.
Give a little bit of your time to me. See the man with the lonely eyes, oh, take his hand, you'll be surprised.
With the Health Roundtable stuff and any of those innovations, we don't judge them on whether they're good or bad. They're just what those people think they've done successfully and put forward. We just look at them and, we might do better than them, but they've actually taken the step to put it forward and show everyone else and give everyone else the opportunity to adopt it as well. The next video that I want to, this is supposed to be a real photo, by the way, if anyone's picked it up, but apparently what the deal is that actually you can't see her clothing at all. That's his shorts. It's quite a neat photo. But so everything's not as it seems, so you've got to dig down a bit deeper and find out what's really going on. Ros Crawford is a SMO, an ED SMO by training and trade, and she's now General Manager of a 170 bed hospital around Brisbane. If we could emulate their length of stay, we would need about 60 less beds in our Tauranga hospital. I think this is about staff engagement.
I'm going to walk around the university, and the other said, you know what, I'm going to wait a year and I'm going to see where people walk. And I think there's something in that, because if we make the right thing the easy thing, if we allow the people, the users, to identify how they naturally will work through a system, but we also work out who are our enablers, our engineers, our doers, our helpers, that will help us go the right way in terms of the right direction, or to not break the rules in terms of, trying to run up the hill backwards and all that sort of stuff, which sometimes we do when our line of sight, when our vision to what we're trying to achieve is unclear. And I think we as a group are probably the enablers of busy people. And I think whether we think about our day-to-day life and the busyness of what we do every day and our clinicians, we need to recognise, I guess, that unless we work with them on this, we're probably not going to get the wins that we want. And that's, for me, one of the key things. So who am I? Well, I'm a FACEM by trade, so an emergency specialist. But I always loved hospital management, except I wasn't quite sure how to get there. So I became an emergency physician first, thinking that I had to do that to be credible. And then I realised that there was this whole new specialty called medical administration, and it really was indeed a specialty. And you only had to do a few degrees to get there, so I did those. And just a few more exams, and I did those too. And I thought, oh, okay. But more importantly, I absolutely love looking after many, not one. And that's why I've got the job that I've got. And it's why many of you fly desks today too. You might not put the tube down, but you change the system so that 100 people can put a tube down effectively or can identify a sick person. But the business that I work with, the business that I'm the general manager for, is a lot smaller with a very tiny bed base. So we have 169 beds, about 26,000 weighted activity units, only 165 million, but 58,000 people want to come to our emergency department. That does create some challenges for us. Are we unique? That's another thing I want you to take away and think about. We're only 48% self-sufficient, so we can't do everything. We can't give you a liver transplant. But we'd like to be able to give you safe and effective care for what we do, which is a whole lot of basic specialties, and we don't have an intensive care unit. So it would be very easy for us to say, oh, we have so many challenges. We don't have an intensive care. We don't have that. We don't have enough beds. We don't have enough beds. We don't have enough beds. Every day we live with the fact that we don't have enough beds. Planning suggests that we need another 170 by 2016. That was, what, this year? So it is challenging to work in our environment. But I know that you all have a feminine workforce, and some of them get pregnant. And that must be really challenging. And you must find sometimes that your government sends you an edict that says by 3:30 this afternoon you must reduce your outpatient waiting list to 0. Because I'm sure it's not challenging at all in any other environment. And I think that's the challenge for each one of us, and that's the universal truth. Everybody in healthcare has too few staff, too few dollars, too many patients, too many accountabilities, yet the patient at heart. And I think we need to acknowledge that, but we need to move on from that, because we can get stuck in problem spotting and not do problem solving. And one is a very active word, and one is a very passive word. And I always worry about morale and engagement, because if we spend a long time in that problem spotting piece, we're not necessarily moving forward. And all the data for happiness, all the data for satisfaction will tell you that achievement is one of the key ways that you as a team will feel that you have control of your own destiny. And I think that's really, really important. It's not to say that not having enough beds is not a challenge. Of course it is. But we do need to recognise that there are certainly things within our sphere of influence and control that we can do and we can make a difference. And I think the challenge also is around the uniqueness index. I see that as a barrier sometimes to progress, because it's a reason why we can justify that it's okay to stay the same. And I would always be very careful, I guess, with language. It's not to say that it's not true. It's not to say it's not the universal truth. It is the universal truth. But if we can acknowledge it and own it and then move on to the next piece, I think we can generally change our morale. So who is a clinician? And I really, really want to talk about that, because I think I'm intensely proud of the clinicians in my hospital, and they're not all doctors, nurses, and allied health. If JFK goes to the Space Centre and he talks to the cleaner, he says, "What's your role here?" And he says, "I am helping a man get on the moon." He doesn't say, "I'm a cleaner." What does that mean for your hospital? Does that mean if your cleaners talk about "I'm a cleaner" versus "I am personally responsible for reducing the infection rate of multi-resistant organisms. I save lives every day"? Does that mean a cleaner is a clinician? And I'm intensely proud that our operational services team at Redland Hospital won the non-clinical innovation award with their waste management program. And they have saved a fortune, and in saving that fortune they have also got a sense of pride and mastery in what they do. They are a key and important member of our team. So if you're an admin officer, does that mean you're not a clinician? Does that mean that you don't save lives? And I think when we start talking like that, we realise the power of words and the power of story. So when we talk about clinician engagement, I would challenge you about who we're going to put in the pile of being a clinician or a non-clinician. I'd also talk to you a little bit about the rules of we inform, we consult, we involve, we collaborate, and we empower. Because what does that really mean? And I would challenge you to think that empowering means doing powerful things within your own sphere of influence and control. Our hospital has never been cleaner. We have an unbelievable correlation between cleanliness of our hospital and our patient satisfaction. We have an unbelievable correlation between our patient satisfaction and their health literacy and their self-management. And that correlates to our possibly preventable hospital admissions. And all of a sudden, we might have more money for more beds. And I think we have to be very, very careful with how we talk. And I try very, very, very hard to remember that every day when I go to work. Because empowering is doing a powerful thing within your sphere of influence and control. And I will be very careful that the word clinician doesn't disempower people that you might find are incredibly powerful in their own way and in their own right. I would say to you, do your reward and impact, do your complexity and effort, and stick in your quick wins. But don't forget your major projects. Your major projects take me 18 months. And they are hard, and they need a lot of work. So you need to time those. But your little tiny ones, the Stranded Patient Program, I found out after a year in my organisation that a patient had been there longer than me. And no one had thought to tell me. She was 1/28th of our entire medical bed stock. She'd been there for about 18 months. And no one had thought to say anything about her. So now, every single Monday, our executive and our major team, when we talk about capacity and demand, we talk about our stranded patients every single week without fail. Now that's a very simple thing to do, and I have been to see 2 families in 4 years. I'm the hospital manager. We need to talk about why it's dangerous for your loved one to stay here. I don't want them to get an MRO. I don't want them to fall. I don't want them to be bored. We don't have enough diversional therapy. We can't offer you enough. And they say, oh, okay, maybe we want to go somewhere that's better because we can't offer you a home. And twice I've had to do that. But the rest of the time, we've just got some systems and programs in place, so some accountability. We enrol you in 7 different nursing homes, not 2. We enrol you in 7 because at $900 a day, it's cheaper for us to enrol you in another 5 with our social worker than it is to keep you for another couple of bed days. And that's why we have the lowest length of stranded patients in the health room table. So I don't know whether that's your problem and whether that's what you want to do on Monday, but never again will I find a patient who's been at the hospital for longer than me, ever. You need to focus on end of life. We've had 1 acute cardiac arrest in our hospital in a year. We've done 462 ARPs, acute resuscitation plans, moving on to advanced care directives in a small hospital. We've done more than hospitals that have had NHMRC grants with one key nurse who goes on our usual business ward rounds every day and starts the end-of-life care discussion. We do not have people dying in our acute non-palliative care DRGs because we have planned for that, and it's such a wonderful thing for patients. They love it, and so do we, and so do our doctors, because we know now that people have that care. Sometimes it's about equipment. We bought an oxygen concentrator that you can borrow from us while your referral for your oxygen concentrator comes through the system. So please don't sit in a hospital waiting for an oxygen concentrator if that's all you're waiting for. Borrow ours. Just do it at home where you can watch television, any one you like, because here we're going to charge you $22 a day and you don't even like the channels we offer. But most importantly, everything is about the interface between teams, and that's why you need to work on what the word team is. Because if the team is the emergency department and it's not the medical and emergency department for a patient on the interface between ED and emergency and internal medicine, then you're probably going to find there is money and resources and value on the table that you're leaving off. And you must consider consultant-led care. We round every single day with a consultant. It is cheaper for us to use our beds better. I couldn't afford a VMO that comes on Mondays and Thursdays. Our average length of stay is 2.41 days. I cannot have a VMO on Mondays and Thursdays because you just cannot look after our patients. They are not there that long. So only fix what's broken in the first instance, because people get very funny about change. So if you can just do a couple of little very, very broken things, the rest of it needs to be about the capability of your team. So I think that's something really interesting, because you always think, oh, if I fix the process, if I fix the process, if I fix the process, but if you actually just develop your people, the process just gets better on its own. And what I care about is the outcomes. And I think that's really, really, really important. So we've spent ages on upskilling and succession planning. And that's why we have a team of 4 at this meeting. And I think it wasn't always the things we thought it was going to be. It wasn't always money or extra staff. It wasn't about efficiency. It was fixing those things. But you can't get away from some major bodies of work. They are really big and they're quite disruptive. So we've done 4. We do one every year, every second year. I pretty much have babies in the alternate years. I won't be doing that anymore. But I've got a 2-year-old and a 1-year-old. So you can see that there's a little bit of gap in our bit. But if I can just talk about a couple of things we've done. So the last 3 are probably a bit interesting. The F1, or the fitter program, is where the operating theatre did a whole body of work around being a race car. So having to have everybody start at the same time and be there like a pit stop at the beginning. That was their story. It was what they wanted to call it. I was delighted, because it means that we're now putting about 20 to 30% more through the same physical infrastructure. What does that mean for patients? Our SOAR program, or our Specialist Outpatient Redesign program, I also don't mind what that's called. We like to give a bottle of wine away wherever we're naming something, if we are going to a body of work. But that was also about specialist outpatients, and we've been able to reduce our outpatient waiting lists by 70+%. We've got no ultra long waits, and we will get to 0. But it's not a project. It's a new way of working. But sometimes that very disruptive change needs a little bit of help and assistance. So that's when I would use the word project. And now the ED. We might be doing a program of works in 2016, maybe, hypothetically. But you're probably never going to be finished and done, because once you've done that, you've got to go back to the first one, because it is what it is. But when you start to see some of the results of some of the work that you do, you think, oh, yeah, I guess that's a plunging line of reduction of specialist wait lists and long waits. And that's very rewarding for the team. We only focus on what our team can do in a reasonable day's work, but everybody had to put their shoulder to the wheel. So I personally did an audit of our paediatric outpatients. Why? Why would I do that? Because I wanted to know the answer personally, because it was outside of the scope of the project, and I thought, right, well, I want to find out about that, so I'm going to do that piece too. You've just got to go back to the data. But most importantly, you need to develop your pipeline of leadership people. And your leadership people can be a grade 5 nurse in the emergency department, or an allied health practitioner that works in advanced physiotherapy. And when they become leaders in their own right, you'll realise that you cannot keep up with your team. And we're seeing that all the time. I mean, I didn't know that hyperemesis gravidarum was going to become a hospital in the home diagnosis. I really didn't. I think it's fantastic that that's now an opportunity for someone to not come to hospital who probably doesn't want to be there. But also, we've got 19 bed spaces in our emergency department. If I can find that that lady with her toddler is at home without her husband and her mother and her toddler in our emergency department, then what does that mean for our emergency department staff, that they now have time and space? So when the emergency department comes to work, they probably don't think, oh, thank God we've got a hyperemesis gravidarum program in the hospital in the home. That's going to make my life better today. But it will. But lots of micro steps by lots of micro people will make a difference. One child that's hungry, when there's millions more who are hungry. Because the psychology says that your brain cannot process the responsibility for all of those starving African children. It is too hard. So you need to be able to change your language and your narrative to talk about the one patient who was the 80th patient waiting for a colonoscopy out of clinically recommended timeframes who got cancer. And then all of a sudden, you'll find that the solutions to that problem are slightly different. We moved a whole stack of old equipment that was sitting outside our endoscopy suite, and we put another patient there so that they were never waiting for the next patient to come down from far away. and our turnaround times between procedures reduced significantly to the point we can do, depending on the clinician, up to double the throughput in the room. And there's 1,900 people waiting for care. We had a 700% increase in referrals. So I could use the language and say to people, there are 1,900 people waiting for you. But I could say there was one patient who had a cancer that we could have done better for. But at the point we get to 14 points a list, I can't use that language with you anymore because it's overwhelming. But what I can say is that we're doing the best we can with the resources that we have available. That we have 80% utilisation of one single procedure room with 14 points, morning and afternoon, every single day. We can talk about our cancellation rate by hospital being 0. And we can make sure that we anticipate that no patients will not realise the value of what they're being offered. I would say to you, you really need to consider the use of storytelling. Storytelling is one of the most powerful tools in your armoury. And that's to use a patient through a complaint, a voice through a clinical incident, particularly if it's backed up by a wider or systemic problem, and use that patient's voice to help your clinicians see why some of this stuff is so important. But as they develop their own key capability, they'll be telling you of the things they want to do, and you'll be finding out about them after the fact. I knew about our waste program, not after they won, obviously, I knew about it well before then, but I didn't know that our cleaning team were frightfully excited about waste sorting. They developed that program of work all on their own. And I also recommend about self-management. So I use the Agile Principles. I use a lot about agreed scope and hard endpoints. I like to talk about outcomes, not processes. I don't care how the Indigenous liaison officers want to follow people up, if it's in hospital or out of hospital. It makes absolutely no difference to me. But I expect every Indigenous client who's a Dharma to be assessed for why they went home and gets medical advice. And if she's a woman with 4 children who has to take her children to school and she can't stay, is that a Dharma or is that a negotiated discharge where we maximise your health as an outpatient? Because maybe we can get you to come to see us every day. We have a nil GP program. If you come to our emergency department and you don't have a GP, we will find you one. And if you want a girl that works on a Friday, we will find you a girl that works on a Friday. And you know what? They don't come back. We have 1,200 people seeing GPs for GP problems. Now, is that a boring solution? Or is that something that is just redesign? But that's 1,200 people that you don't necessarily have to wash your hands and triage and find a space for them in the ED and talk to them about their sore ear. But they might also get a flu shot and speak about their pap smear. And then you might not have to treat them for their, colposcopy and their gynae cancer. So we think very hard about value every time. And as you develop your learning culture, you need to remember that culture eats strategy for breakfast. So you have to manage your culture. But the most exciting thing is if you just work on your 5 Ps, your people, your power, your partnerships, your practice and your power of the team, you will get to where you want to be.
So these innovations we would like you to still shamelessly take back. As I said, they're all in our library. I'll make my slides available as well. But have a look at them in the library. Send them to your staff and let them have a look at them to say, could we do that? Could we do that here? Could we do that here? This was a presentation and a winner of one of our awards at the Hospital in the Home meeting last year. It was the team from Dubbo who are using registered nurses to insert PICC lines. They have 96% of all of their PICC lines now being inserted the next day after business, rather than having to wait for a consultant to insert one. Sometimes that can take 3 or 4 days, so 96% within a day, which is pretty good. This is from our paediatric meeting. At Auckland Hospital, they do day-stay tonsillectomy. And in most of our health services, it's an overnight procedure. And many of the surgeons say, oh, you can't do that. These guys have been doing it for 15 years. They've been doing it for 15 years. It's protocol driven. You have to live within an hour of the area. They've got choreography, so the surgeons have to do a list in the morning and list in the afternoon. So they do tonsillectomies in the mornings and minor procedures like grommets in the afternoon. So you have to be there to check the patients, because most of the bleeds happen within 4 hours post-operatively, and then they get them out in a day. That's a win. If you can talk to your surgeons about that, they say it can't be done. These guys have done it. They're internationally published on it. Worthwhile looking at day-to-day tonsillectomy. This is some work done by a junior doctor, Martin Senavaratna, just to try and get choreography with documentation. So the ward rounds lack structure and clear lines of communication. So they've got it's an app. He's developed an app so that different staff members can write in the information that they need. Yeah? It brings it all together. You get a combined plan. And you also get task allocation. You get task allocation, so you get choreography, because sometimes you'll find two people doing exactly the same task. Yeah. So they've got task allocation and a priority system. And he won one of our HRT awards in the innovation meeting the year before last. These are some junior doctors from the Prince Charles Hospital who've developed a little app that helps with discharge summaries. As I was saying yesterday, why is one of the most complex and important pieces of documentation written by the most junior staff who haven't been trained in how to do it. And they haven't been trained that you can't just put in the pathology results and if it's an abnormal result, and you can see it's abnormal if you don't write abnormal, it can't be coded that way. So it's a training and an aid memoir for junior medical staff. And it's had a huge impact in changing people from the B to the A category. This is a completely revolutionary innovation to reduce falls. Move the bed against the wall. It's one of those small effort, large benefit things that you can do that's had a huge impact on reducing falls. Yeah. Really simple to do. Yeah. And that's not only in inpatient units, think about it in outpatients as well. Yeah, think about it in outpatients as well. This was an award winner from the year before. This is the Western Health Diabetic Foot Clinic. They've been able to, by putting in a diabetic foot clinic, they've been able to reduce amputations by 44% and acute admissions by 37%. Yeah. It's better than a surgical procedure. Yeah, being able to, than a drug, sorry. Better than a drug, some of those effects, to be able to do that. Diabetic foot clinic. Yeah. This is some work that was also an award winner the year before last. It comes from St Vincent's Hospital in Melbourne, who've put in the productive ward program. They've had dramatic reductions in length of stay. They've been able to double their direct care time. When they first audited, nurses spend 30% of their time of an 8-hour shift with the patients. Yeah. 2 years later, they spend 60% of their time by taking a lot of the waste out of the system. Sue White, whose work this is, she's come in under budget at $250,000. The key part of the innovation that I wanted to show you was this. They've got a patient bed board behind every patient's bed, which is nothing revolutionary, but what's on it is. There are two things that they do that are revolutionary. They ask people what their likes and dislikes are, so you can have a conversation with them. Yeah, to open a dialogue. And the most revolutionary thing they've done is they've put the telephone number of a loved one on the board. So when they round, which they do every day, once I've seen Chantel, I say, Chantel, can I ring that number? And you say, yes, because you've given permission. And then I will ring her husband and say, actually, Chantel's doing really well. She's going home tomorrow. Yeah, could you come pick her up? Yeah. They've reduced the amount of interruptions to their ward by 50% by controlling the telephone call. Usually you get the inbound call in, yeah, and so that's all stopping now. They're making outbound calls. They're getting choreography in their health service. At Wollongong, they've got this amazing program called Punching Windows Through Silos. The program is about reducing readmission rates, and they've done some really amazing things. So one of the things that they've done is for all of their Indigenous clientele, you get a telephone call 48 hours after your discharge, just to make sure that everything is okay. They've got referral pathways, but the thing that they told us, which was quite revolutionary, they've done a deal with a local gym. So rather than wait for rehab in the hospital, the physios from the hospital have trained and accredited gym instructors, and they're filling their gym in low peak times. Yeah. And patients are going into the community to exercise rather than sending them the signal that you can only exercise at the hospital under the supervision of a physiotherapist. And by the way, you'll have to wait 12 months for that. That's what's happened to their readmission rate after doing that. Yeah. They've gone from 20% to under 10% by putting that program in place. This is a program that's come from Barwon Health. It's still in trial. They're giving iPads to patients with chronic disease and sending them home with that. And we always say, let the patients monitor. Why are they sitting in a bed having that happen? So they send them home, all their vitals are monitored. Yeah. It gets sent back up the line, and the staff at the hospital are monitoring that. One of the key things that they've done is they're also monitoring symptoms, yeah, and they're monitoring people's psychological state, because the research shows us that the biggest driver of hospital readmission in chronic disease is not your physiological state, it's your psychological state. It's the anxiety that drives a lot of readmission, and so they're measuring anxiety, and when people's anxiety goes up, they give them a call, rather than them calling the ambulance, and you know what happens after that. Bendigo Health are in the top 5 for the round table for both the surgical and knee DRGs. They've put in place, you may have seen it at a few of the other workshops, the patient pathways with the tick box, what happens on day 1, what happens on day 2, what happens on day 3. They've now implemented this visual pathway that they give patients perioperatively, and they've created a video which plays in the waiting room that tells you what to expect from your surgical journey. Tell the patients what the standard is and let them audit against it. We're just going to move to the MARTA, which is prosthetics. They have, for me, this is one of the sacred cows in healthcare, is they've been able to reduce costs in prosthetics because there was huge variation in cost, and you saw James present some of that data yesterday. They've been able to they've got 2 providers for prosthetics, so they've been able to standardise prosthetics. What Richard was telling us is that this has had not only a significant reduction in cost savings, they've met their compliance targets with just using only those 2 suppliers. They get good support. He was telling us that the CSSD are loving this because they don't have to worry about 20 different types of things to clean. So they've got choreography again. In Christchurch, this was at our primary care meeting, our reducing readmissions meeting. Their innovation to reduce readmissions was to identify the frequent attenders and give them a fridge magnet. So they found that the root cause of many of the readmissions was that the ambulance drivers would turn up, measure their vital signs, which were elevated, and bring them to hospital, not realising that most of these people's resting vital signs were elevated. So they've given them a fridge magnet with an action plan and what their resting vitals are, with the first port of call being go to primary care. If you don't have a GP, they've done a deal with some of the large super clinics, yeah, and you get sent there first. It's had a huge impact on their readmission rate. I don't have time to show you this video capture, but it's been one of the key innovations from the MARTA. They've got hundreds of these short little videos for training, and I want you to think about how you could use some of that for training people in how to interpret their own reports. We use them for Health Roundtable, So you'll see that there are some short little training videos that are up. So if you use some type of video capture, if you don't know what video capture is, as my 13-year-old daughter says, just Google it, Dad. If you Google video capture, there are some pieces of software that you can buy that basically record you in front of your laptop. Yeah. And you can play back those short little snippets to people. It's a really effective way of training people, and you don't need to stand in front of 50 people every week educating them on how to use your system. I wanted to show you this for two reasons. The first is it's a really simple innovation. It's called a QR code. Have you seen those before? Yeah. We use them in many other aspects of our lives. They're in magazines. Lots of hotels use them. But we tend not to use them that much in health services. Paul McNamara presented at our mental health meeting. They're putting them on their perinatal mental health forms. He said a lot of the women that access their service are socially disadvantaged and financially disadvantaged, but they all have a smartphone. Yeah. And they lose the literature that they have. Yeah. But what you do with this is you can just scan it. If you get a QR code reader on your phone, if you don't know how to do any of this, just Google it. Yeah, you can download the QR code reader. They put this on all of their forms. You can send people. We've seen some health services that are putting their directions to the health service as a QR code. So you actually get to the right spot, because there's a lot of time people get lost and there's waiting. It's a really simple thing that you can put onto most of your forms. One of the things I discovered that you can do with it is you can put up to 250 characters of text. So if you want to give someone an instruction, they can scan it and they've got it on their phone, for example. You could put the top 20 reports and a quick link with QR codes to someone, and they could just scan it and it would take you straight to that website. Some really simple, effective things you can do with QR codes. The thing I wanted to leave you with was a presentation that was given to us from Kaiser Permanente on the use of video. For those of you that have bought a house recently, you can usually tour most houses by looking online. Why can't you tour your hospital by looking online? Yeah, for elective cases, for outpatients cases. Kaiser were telling us, for their small membership of 23 million people, they've segmented their market. So if you have an outpatient reminder, they send you an email. We collect people's name, date of birth, and their smoking and drinking status about 50 million times, and we never usually grab their email and their mobile phone number, which they're constant. So they take their email addresses, they find out what cultural background they come from, and when you get a reminder, you get an email, but you also get an embedded video from a consultant of your cultural background saying to you, we'd like you to come for this appointment. Yeah, because they found that increases attendance. Yeah, really simple things to do.
This guy conducted a choir with 185 individuals all around the world just through PCs and electronically. So there's 185 people all around the world, and he conducted them from one place. So Koawatia, I don't know if everyone knows about that. I know a lot of people do, but counties Manukau they invested many millions in a big infrastructure and specialist improvement people, and they are leading the country in that kind of thing. They're also quite well recognised around the world for stuff that they're doing, and we are quite keen to be a part of that. And so we met with them just to firm up whether we can, make more of a formal link with them. So they're quite keen to have, it might be a virtual community that we can all kind of join in. So definitely Service Improvement are keen to be a part of that. They have so much knowledge and experience and access to courses and all those sort of things that we definitely are keen to be a part of and tap into. So that would extend our community.